Good evening, guys. I'm Dr. Mukul here, your orthopedic instructor at Medway, and I'm connecting here with you to give you a quick recap of this subject orthopedics before your final exams. So, just trying to set up the chat box and so that I'm able to see your comments as well. Okay. Fair enough. So I think we can just get started with this quick recap of orthopedics part, and I'm especially focusing today on the fractures because a lot of questions, come in this FMG exam, especially based on fractures. Traumatology is actually a separate and a very vital subject if you talk of the foreign countries, although it is little underrated here in India. But still, I would say that if you are thorough with the fractures, no way that you are going to at least miss 5 or 7 questions. 5 or 7 questions would almost always be a part of your curriculum in case you are attempting an FMG exam from the orthopedic side. So just to make sure that you don't miss out on anything, I'm giving you quick recap of the fracture areas, discussing some repeat questions, some important questions, okay, as we go along. So the first published report of the use of X-rays in orthopedics belongs to this man. Who is this great man? Now all these people in front of you have been important contributors to the field of orthopedics. Dr. Robert Jones. He is the gentleman who introduced X-rays to the field of orthopedics actually. So that is the answer here. This gentleman gave us this great innovation, that is X-rays. So for this great contribution, this is the gentleman who's got this title, the father of modern orthopedics, because it's pretty unimaginable to think of orthopedics without the X-rays. That's what has revolutionized and modernized the orthopedic technology, the X-rays. So that is the work by Dr. Robert Jones. Apart from him, some other people have also contributed a bit. This man, Dr. Nicholas Entry, he is the gentleman who actually coined this word orthopaedics. This particular word was coined by this man. Now this word ortho basically means straight, and this word pedics basically means child. So orthopedics actually started as a branch to make a child straight. So correcting the deformities was the essence with which orthopedics started. But then eventually fractures, trauma became bread and butter for an orthopedic surgeon. That's what now makes up the sense of orthopedics. But yes, for coining this word, this gentleman, Nicholas Henry, he is called the father of orthopedics. Okay. Now, these two gentlemen, Dr. Bowler, Dr. Thomas, they are especially popular people because they have devised some special splints. Bowler, he has devised the Bowler bronze splint, okay, and Thomas, he has devised a very popular Thomas splint. Now these splints are basically used in orthopedics to immobilize the lower limb fractures. So fractures involving lower limb, if they need immediate immobilization to decrease the pain, we use these special splints for that purpose. So Thomas splint and Bowler bronze splint. Okay, so these are the splints we use to immobilize lower limb fractures, and they were given by these two popular people, Bowler and Dr. Thomas. Dr. Thomas also has some other contributions to his name, like he is the one who introduced the cervical collars, the collars that we use uh, for cervical spine injury cases. They were also devised by Dr. Thomas. So that's a very, very important innovation. And then let me tell you something unimaginably important. This is also the gentleman, Dr. Thomas, who is credited with this very important innovation. He is the one who devised this very popular test that is known as the Thomas test. Thomas test. So what is Thomas test? Let me just brief this also to you, because it's just been one of the questions in one of the earlier FMG exams also. Thomas test is basically a test that helps you to detect a fixed flexion deformity involving the hip joint. So what is this fixed flexion deformity? What is the Thomas test? What is the relevance? Let me just brief this also to you. Now sometimes there is a chronic pathology in the hip, like avascular necrosis, tuberculosis. Now all these chronic painful conditions lead to spasm of the hip flexor muscles. So these flexor muscles would undergo spasm, and there would eventually be a flexion contracture resulting in chronic painful conditions. So most of the chronic painful conditions would eventually end up with a flexion contracture. Okay. Now if there will be a flexion contracture, means the flexor muscles will become tight and contracted. The body of the patient would bend like this. So walking would become very difficult. So body has to adjust to a flexion contracture. And the adjustment to a flexion contracture is by increasing this lordosis in the lumbar spine. So how body adjusts to a flexion contracture is by increasing the lumbar lordosis. This curve that you see that has been increased is what I am calling as lordosis. Okay. So again I'll just brief you. Someone has a chronic painful condition in the hip, maybe AVN, maybe TB, maybe some other reason. There will be a flexion contracture developing in the hip. But body would adjust to the flexion contracture by increasing lumbar lordosis. So even people with a flexion contracture will be walking straight, but with an exaggerated lordosis. So looking at these people, it's very difficult to know whether the hip has a chronic pathology. If you want to find out the chronic pathology in the hip, this lordosis has to vanish. Only then can you quantify, measure the amount of this flexion deformity. So this exaggerated lumbar lordosis is what is neutralized by the Thomas test. I'll just show you how. This patient has a flexion contracture on this hip here. Now I have flexed the opposite hip, and as I am going to fully flex the opposite hip, the back will go straight, touch the couch. So the back becomes straight flat with the couch, so that lordosis is gone because you have pushed the opposite hip. So as this lordosis goes away, the flexion deformity of the hip comes back. So now you can measure the angle of this flexion contracture with the couch, and you will get to know the degree of the flexion contracture. And if there is a flexion contracture, get the X-rays done. There is some chronic source of pain in the hip. So that is the purpose behind this Thomas test. So this was also given by Dr. Thomas. Okay, and this is a test that is used to detect a fixed flexion deformity of the hip joint. So I hope you are clear with all these names. You are well introduced to all these names now. You understand their relevance. You are familiar with those minor kind of innovations they've given that can sometimes just be MCQs in your exams. Okay, so done with that. Now an 8-year-old boy, he has had a fall on outstretched hand and is landed up with a fracture. What is the most likely possibility? Now when you talk of 8-year-old boy, there's a child who's coming in front of you and he has a fracture. Now most people would be inclined to take green stick fracture here, because green stick are special fracture patterns that are commoner in children. So the commonest fracture pattern you find in children invariably is green stick, and you are very much familiar with these fracture patterns, green stick. But green stick fractures are specifically fractures that involve a direct impact onto the bone. The bone that will fracture, like the forearm bones, would be directly hitting the ground. Here the examiner has mentioned that there is a fall on an outstretched hand. So here, as you have fallen, your hand has rested on the ground, not your forearm bones. So here the hand is bearing weight. So there is an indirect load on the elbow. So when you land and you put your hand on the ground, the upper limb becomes the weight bearing bone and elbow takes up most of the load. So in such particular scenarios, the distal humerus would generally fracture and the child would land up with supracondylar humerus fracture. So I hope you got my message. If there is a child who falls, he lands up hitting the forearm bones on the ground. There is a direct impact on the forearm bones. That is where you talk of green stick fractures, and these are generally the commonest fracture patterns you find in children. But sometimes when this child would fall, rather than landing with the forearm on the ground, he might just land up with his hand on the ground. So when the hand is placed upon the ground, the direct impact of forearm is not there. Elbow takes up the load, distal humerus fractures. So this is where you get a supracondylar humerus fracture. Clear with that? Clavicle is the commonest fracture you don't find in a child but at birth, and overall also we generally take it as most common fracture in the field of orthopedics. And these torus fractures, they are also special fractures you find in children, and the classical thing you find over here is buckling of a single cortex of bone. So bone has two cortices. One of the cortex of the bone is pressed inside like a buckle of a bag. So that's exactly what is called as a torus fracture. So I hope you are clear with all these terms. All these fracture patterns are seen in children, but they are generally due to a direct impact. When there is indirect impact, like you're landing on a hand, elbow taking up load, that is where you find supracondylar humerus fracture. And if you're talking of a child who's just being born, that is where you have to talk of a clavicle fracture. So I suppose that gives you a fair enough good idea as to like what pattern of injuries are you expected to see. Okay, in children's age group with different kind of injury patterns. Fair enough. So I hope everything is okay. You guys are able to hear and understand everything. The only issue I am finding, I am unable to see the chat box, but let me see if I can somehow try and access the chat box also. Okay, so that I am able to get to your queries also. Okay. Let me just try and sign in and okay, I'll just try signing in and maybe I'll be able to access the chat box also. Now you have to identify this very special fracture pattern here. Now if you see, this is tibia and this is fibula. So here the entire fibula is okay. It is the lower tibia that is having a spiral fracture. Now this is another fracture pattern that is almost exclusively seen in children. This particular fracture pattern is called a toddler's fracture. This is basically a spiral fracture that involves the lower third tibia, and you classically find this again in children. So that's exactly what is called as a toddler's fracture, a spiral fracture involving the lower third of the tibia. That is a toddler's fracture. Clear with that? Now moving a little further, one of my favorite questions. The term Bennett's fracture is used to describe. There are 4 options in front of you. Now Bennett's fracture is a very popular repeat MCQ. Most of you are generally very familiar with this. But still I find people, they many a times create problems. Perhaps because they are like, they take it very lightly. The options are so overlapping that you make a silly mistake very often with this question. So let me first take you through these 2 important fracture patterns, Bennett and Rolando, and then let me come back to this MCQ. Now there is something called a Bennett fracture, and then there is something called a Rolando fracture. Both of them are intra-articular fractures, means involving the joint, and they are fractures involving the base of the first metacarpal. The first metacarpal basically means the metacarpal of the thumb. So if this is the thumb, they are fractures of this area, base of the thumb area. Here I am encircling this area for you. So can you see, this is the metacarpal and this is the carpal. So the area that is involved over here is carpo-metacarpal joint. So I'll go back to this. So see, trapezium will be a carpal bone, and this is a metacarpal. So this is the carpo-metacarpal joint being spoken of here, and that is the answer. So Bennett and Rolando, both intra-articular fractures involving base of first metacarpal, so they are involving the carpo-metacarpal joint. The carpal here is trapezium, so trapezio-metacarpal joint. What is the difference between the 2? That is the shape. If you find an oblique patterned, oblique shaped fracture at the base of the first metacarpal, that's Bennett. And if you find like a Y-shaped fracture like this, that is Rolando. So shape is the key. And let me tell you why shape is the key. Because if you see something that is oblique, you can very well imagine that such type of things can slip. So something very, very inevitable with a Bennett's fracture is displacement. Slipping बहुत जल्दी होती है. They slip very easily. They displace very easily. And this displacement is generally due to pull of a muscle by this name, abductor pollicis longus. So Bennett and Rolando, both of them are intra-articular fractures involving the base of the first metacarpal. Bennett is oblique shaped fracture, Rolando is Y-shaped fracture. And Bennett is mostly a displaced fracture, and that is displaced by the pull of this muscle, abductor pollicis longus. A repeat MCQ, abductor pollicis longus. And I hope you've understood a very important point. They are fractures of the base of the thumb metacarpal, so they're actually fractures involving the carpo-metacarpal joint. And since you've seen this X-ray, here there is no thumb fracture here. Actually in this fracture X-ray, I've tried to show you the area of the Bennett fracture, but the X-ray is carrying actually some other fracture here. This is the fifth metacarpal. The neck of the fifth metacarpal is broken. This particular injury is rather even more popular. and that is a boxer's fracture. A fracture involving the neck of the fifth metacarpal. So if you have a fracture involving neck of the fifth metacarpal, that is what is called as boxer's fracture. Clear with that? Now another very challenging pattern of questions that have been troubling you guys nowadays are these kind of questions where there are multiple images and you have to match them up. Now these are all fractures around distal end of radius. So you must be able to interpret these X-rays to come to this answer. So let me take you through the X-rays first, what is what, and then we come back to this and answer the question. Now what you are seeing in the first image here is a very popular Colles fracture. In Colles, you have a fracture around the distal end of the radius, classically involving the metaphyseal-diaphyseal junction. So this would be the metaphyseal fragment, this would be the diaphyseal fragment, and this is all overriding, because any fracture there will be muscle spasm and there will be overriding of the bones. So this is diaphyseal fragment, this is metaphyseal fragment. So there is metaphyseal diaphyseal overriding, and you can see the metaphyseal diaphyseal junction has got the fracture. And another very important thing, if you see the metaphyseal fragment here, it has gone posteriorly, dorsally, पीछे को. So when you see a metaphyseal diaphyseal junction fracture here, with the distal fragment gone backwards, that is Colles fracture. And if you see this metaphyseal diaphyseal junction fracture, but you see this distal fragment gone anteriorly, not posteriorly, it is the reverse of the Colles fracture, and that's called a Smith's fracture. So I hope you are fairly now clear with these two important fracture patterns, Colles and Smith. Colles, distal fragment going back, Smith, distal fragment going in front, and both of them are fractures involving metaphysio-diaphyseal junction around the distal end of radius. Now, something common to both the scenarios, that they are extra articular injuries. They are not involving the joint, because they are fractures involving metaphysio-diaphyseal junctions. They are not involving the joint. Now, if you have a fracture involving joint, it could either be Schoffer fracture or it could be a Barton fracture. So what you would find in Schoffer fracture, the fracture will be involving the styloid process of the radius, like you see over here. This styloid process of the radius is involved. And if it is Barton, you will find an intra-articular fracture involving distal end of radius with a subluxation of the wrist. So please see, here the fracture is going into the joint, but I hope you can see the whole wrist subluxating or dislocating anteriorly. So if there is an intra-articular fracture, the styloid is broken, there is no subluxation of the wrist, that is Schoffer. If there is an intra-articular fracture and the whole wrist subluxates, that is Barton. So I hope you are clear with these queries also. Okay, so clear with these particular injury patterns. Okay. Alright. I hope you guys are comfortable and okay, so I'll just any queries, please just try to let me know if at all there are some queries. Let me see if I can get some chat also. Okay, done. So I'll just come back here. Now this will be the best answer here, choice C, because if you see Kohli's, it is here. If you see Barton, that's here. If you have to see Schoffer, that is here. And if you talk of Smith, that is here. So A, 2. So A is 2. B is 4. C is 1. And D is 3. So that is the best match here. Clear? So I hope you are clear with all these fracture patterns. And yes, I must tell you, Kohli's and Smith fractures, they are particularly popular because of the classical deformities they result in. Kohli's fracture has a tendency to unite in a wrong position. So if it unites with this distal fragment gone back only, a specific deformity results that is popular by this name, the dinner fork deformity. And if you talk about the Smith's fracture, it also has a tendency to unite in a wrong position. And if this fracture unites in the wrong position, like this, the deformity that results resembles that spade with which you dig a garden. So Smith's fracture would malunite to give you that very popular garden spade deformity. So clear with that? So I hope simultaneously you guys are clear, even with the the deformities that are popular with both these fractures. Okay, so I hope you guys are clear with that. Okay, let me see some queries on the chat also, if at all they are there. Okay, garden spade, how to ABC, we will come to that part up. So this particular, okay, you want me to increase the volume a little bit, I'll just bring this a little closer and the volume would go up. So how to differentiate between ABC, SBC, we'll have another session maybe on the other areas of orthopedics. So this particular area I'm mainly talking about fractures. Otherwise ABC and SBC, I would tell you the differences verbally. SBC would have thick wall, there will be no septa in it. ABC would have a thin wall, there will be multiple septa in ABC. Okay, so that is the best way to differentiate between them. And then aspiration can also help you. If you aspirate SBC, it will be clear yellowish fluid. If you aspirate ABC, it will be blood. So either ways you can differentiate between them. Okay, fair enough. So no more queries, I suppose. Okay, I hope my voice is now improved. I'll improve upon the volume part, not a problem. Okay, fine. Sure guys. So I think the background noises have gone down and my volume has improved. Fine. Okay. Now there's a question over here as to the recommended treatment for this particular scenario. Now what you see in front of you, I would simply say that this is an open fracture. So this is open fracture because this is a fracture and you can see this big wound, nearby a fracture site. Okay. Open fracture. So let me first give you the definition. What you find over here is that the fracture hematoma would drain from a wound nearby a fracture. So there will be wound nearby fracture from where the fracture hematoma will escape. That is what is open fracture. Now open fractures, how do you manage? So I'll tell you. Open fractures are managed by external fixation, and closed fractures are managed by internal fixation, where there is no wound. The idea is very simple. Open fracture, you have a wound, so there is a communication with the environment. So there is a very heavy risk of infection. So when there is a risk of infection, we do not put any metal at the fracture site, because that would have very high risk of getting infected. Internal fixation basically refers to all those metal implants we put inside the skin, like nail plate, screw wire. This is done for uh, close fractures. So internal fixation is basically any metal device like nail, plate, screw, wire, okay, anything that you put inside the skin for fracture fixation, that is internal fixation. So let me tell you, this K wire fixation is also internal fixation. Nailing is also internal fixation. So option C and D are just types of internal fixations only. So all these internal fixation stuff will be used for closed fractures. Internal fixation device is not used for open fracture because it will be infected. So open fractures are managed by external fixation. Clear? So the treatment for open fractures is external fixation. So I'll just show you. That is how an external fixator looks like. Suppose this is open fracture of tibia. So you put 2 pins in the normal bone above, you put 2 pins in the normal bone below, and you connect these pins outside the skin with rods and clamps. So there is no metal at the fracture site. That is external fixation. A nail plate would be spanning the fracture site. So when you have metal spanning the fracture site and they are inside the skin, that is internal fixation. When you find most of the metal outside the skin, that is external fixation. Clear with that? Now external fixation, we generally keep an option for open fractures. Internal fixation devices, wire, nail, anything, we keep as an option for closed fractures. Clear with that? No, not all open fractures would undergo external fixation, I'll tell you. Precisely speaking, open fractures are categorized by a very important classification that is called Gustello-Anderson classification. The classification is basically based upon the size of this wound in open fracture. See, type 1, type 2, type 3. In type 1, you will have a wound that will be like a puncture wound, less than 1 centimeters, tiny wound. In type 2, the wound size would go somewhat like 1 to 10 centimeters. And when you talk of type 3, the wound size would invariably cross 10 centimeters. Clear with that? Clear with that? Now this type 3 category is further divided into 3A, 3B, 3C. 3C. Here you would have a vascular injury in addition to the open fracture. You have an open fracture, but there is a vascular injury also. That will go to type 3C. Now what is type 3 and 3B? 3A, there will be some soft tissue cover left on the bone. The nearest soft tissue covering the bone is periosteum. So here at least periosteum will be intact. But when you go to 3B, what you find that even the periosteum tends to be disrupted. So if the periosteum is also disrupted, the bone will be like visible, dikhegi. You can see the bone. Like here, you can see the bone. So the type is bound to be 3B. But you can see the pulses are palpable. It's written here. So vessel injury is not there, otherwise this could have been type 3C. Clear? So you must categorize the fracture first. What kind of open fracture you are dealing with, because the reason is Type 1 fractures can be managed by like closed fractures with internal fixation, type 1 injuries. But when you go to type 2, 3, 4 injuries, this is where external fixation is the rule. So type 3 we always go with external fixation, type 1 we can go with internal fixation even in open fractures, to be precise. So clear with that, guys? So I hope you are clear with this Gustlow Anderson classification. अच्छे से समझ में आ गई है. You've understood the treatment part. External fixation we keep for open fractures because there's a risk of infection. We don't want metal at the fracture site. Internal fixation we generally use for closed fractures. Clear with that? Okay. Now let me tell you this small concept also, like how do we treat these closed fractures. So open fractures you understand we treat with open fractures we treat with external fixation, but a little bit more about the treatment of closed fractures. Now suppose someone has a forearm bone fracture. So someone has a forearm bone fracture. We try to manipulate and reduce it. Reduce means align it. And we are checking under some portable X-ray machines we have with us in the emergency while we are doing these reductions. The moment our X-ray machines tell us that the bones are aligned, we put a plaster of Paris cast. So closed fractures, our first step is mostly closed reduction plaster application. Closed reduction means I'm not draining the fracture hematoma. Like in open fracture the hematoma is drained, so open reduction hematoma is drained. Closed reduction you don't touch the hematoma. So first we always try to treat fractures in a closed way by applying plasters. Now you are manipulating, but the bones are not coming in one line. So there are some scenarios where this closed reduction is just not feasible because of some entrapped soft tissue at the fracture site. So this is the scenario where you have to open up the fracture. Opening means you are going to give the incision, go to the fracture site, that will drain the hematoma. That is open reduction. And if you do open reduction, you have opened up the fracture, you are bound to fix it with a nail or a plate. You are bound to do internal fixation also, fixing with that metal inside the skin. So this is the general protocol or general approach to any fracture by an orthopedic surgeon. He sees a fracture, he tries not to take any surgery, not to give any skin incision, not to operate. He tries to manipulate and align and put up a plaster. But when with manipulation reductions don't come, bones don't align, he's bound to open up the fracture, giving skin incisions, reaching the fracture site to take out the intervening tissues, aligning it. And if he opens up the fracture, does the open reduction, he always fixes the fracture also with metal, doing internal fixation. Clear with it? So this is our general approach in any fracture. Now just of late, this close reduction plaster application, this part is shifting to close reduction internal fixation. This approach, close reduction internal fixation, close reduction, no incisions, internal fixation. We put metal inside the skin. Even this is possible, but this is only possible at few places. Few places. Like if you want to nail a long bone, or if you want to put screws in neck of femur fracture, or if you want to put K-wires in this fracture supracondylar humerus, the distal humerus fracture. I'll just show you this part also. Okay, I'll just explain to you this part also. So just understand, if I have to nail a long bone, my incision to insert the nail will be far away from fracture site. Like I'll just give you an example here. So this bone is femur, and I decide to nail this fracture here. So my incision will be here, from where I'll insert the nail over the greater trochanter area, and then I'll drag in my nail into the shaft. And when it will reach near the fracture site, I'll manipulate the femur to align the bone and then push in the nail into distal fragment. So my small incision over here will not drain the hematoma over here. So the reduction remains to be close reduction in nailing. and you have a nail inside the bone, that is internal fixation. Similarly, screw fixation in neck of femur. Sometimes you have a neck of femur fracture here, and you give a tiny incision over the lateral side of the thigh, and under X-ray control you put 2-3 screws across the fracture site. So the hematoma is over anterior side of the thigh, and the small tiny lateral incision cannot drain the hematoma, so reduction remains to be closed, but screw inside the bone, internal fixation. So these are some special scenarios where your incisions don't drain hematomas, so reductions remain to be closed, but you have metal inside the skin, so internal fixation. But you can see any dam fracture, our first approach is always closed reductions, no incisions at the fracture site, no drainage of hematoma, because hematoma helps in fracture healing. So we try to keep the hematoma preserved. If we can fix with some metal without disturbing the hematoma, we do it in such scenarios. Else we apply plasters. So we keep close reduction as our priority. Wherever close reduction is not feasible because of some interactive soft tissue, that is where we move to open reduction, internal fixation. Open reduction, internal fixation is the first step only in one scenario, and that scenario is called fractures of necessity. So fractures of necessity are the only exceptions where we keep open reduction as the first step. Clear? Fractures of necessity. This term comprises intra-articular fractures, means fractures involving the joints. The second group that comes over here is that very popular Glazy or that Monteggia fracture. And the last thing that comes over here, a fracture involving the lateral condyle of humerus. So in these specific scenarios only, we take open reduction as first step. Okay. Clear with that? I think some problem with the video. Okay, let me see. I think maybe a bit of a net issue. Okay. Okay. I hope guys there is not much of a lag now. Yes. Okay. Because I received some complaints regarding lag in the video, but I hope that lag is okay now. Yes, please just let me know by typing your message in the chat box. Okay, so I was telling you that these special scenarios we keep open reduction as first step. See, why in intra-articular fractures? Intra-articular fractures will be fractures involving joints. Joint fractures, they need 100% reduction, and 100% reduction will always require open reduction. If there is no 100% reduction, there will be osteoarthritis eventually developing in the joint. The joints would degenerate. So that is why intra-articular fractures be managed by open reduction. Glazy and Monteggia are very popular fractures. In Glazy, you have this lower third radius broken. The distal radioulnar joint dislocates. Monteggia, you have this proximal ulna gone. The proximal radioulnar joint dislocates. So because of these radioulnar dislocations and simultaneous fractures, these fractures also are better managed by open reduction. So here you have a fracture plus a radioulnar joint dislocation. So two things in one go. So it is always also better managed by open reduction. And a fracture of lateral condyle of humerus. tends to be intracapsular, within the capsule. Now fracture within the capsule tends to be lined by synovial fluid. And now our research has told us this synovial fluid inhibits bone union. So if synovial fluid will be drained by open reduction, union will be faster. So you can very well imagine, suppose we are going with open reduction here, the synovial fluid will be drained, union will be faster. So open reduction has specific benefits in these three fractures, the fractures of necessity. So fractures of necessity, we keep open reduction as first option. All other closed fractures, we keep closed reduction as first option. Some scenarios we can reduce closed and use metal implants, internal fixation devices. So here treatment is closed reduction, internal fixation. Some fractures we can't use a metal, in closed reduction we apply plasters, but we always keep closed reduction as first option. Whenever closed reduction is not possible, we move to open reduction. And if we are dealing with fractures of necessity, we keep open reduction as first choice only. Clear with it, guys? Clear with it? Clear with it? So let me just try and give you a practical example. This is just a repeat question from the previous FMG exam. Management of a tibia fibula fracture. Open reduction, internal fixation. Wrong. Because this particular step will be chosen when closed reduction would fail. Because first step will always be closed reduction. Clear? External fixation wrong, because this would have been the choice had this been open fracture. Here examiner has mentioned nothing, so we take it as a closed fracture. So that is why I am removing external fixation. Now a tibia fracture would best be nailed, because nailing is closed reduction, internal fixation. So here it is closed reduction only. That would have been best choice. But here it says closed reduction with plate. Impossible. Not possible. If you put a plate, you will have to open up the fracture site. Plating is always and always coupled with open reduction, never closed reduction. A nail can be put by a closed reduction, never a plate. So this choice is also wrong. So if you can't put in a nail, you can apply a plaster. That is the alternative, as I have explained to you here very clearly. So if you can't put in a nail, you can apply plasters also. But closed reduction should always be first step. Either you fix with some metal without draining hematoma, or you apply a plaster. So here in this particular scenario, the best answer would be this. Otherwise, better than even this would have been nailing. That is closed reduction, internal fixation. So I hope you guys are clear with this question also. You have understood the whole scenario, the treatment principles. Okay. So you have understood this all. So I'm just looking at the chat once again. Any queries, please feel free to ask. कोई समझ में ना आ रहा हो, you want me to repeat anything, something else is there in your mind, or something else has been taught in your classes in your colleges, so please just feel free to ask me regarding it. Okay. Now 6-year-old girl has presented to the emergency department with elbow pain. There is swelling in the elbow. What is the vessel at danger? So if you see this x-ray, distal humerus has broken, and there is a small girl with that fall on the hand. So this is a classical case of fracture supracondylar humerus. And this particular fracture, it is the brachial artery that is at risk, because this is a fracture notoriously known to develop some terrible complications. Clear with that, guys? This particular fracture is also notorious to go into a very dangerous complication. Apart from vascular injury, that is compartment syndrome. And if you read these lines, numbness in the fingers, pulse feeble, that is pointing towards the development of compartment syndrome. Let me brief you a bit about this very important fracture, supracondylar humerus. This is a fracture where the fracture line is passing through the olecranon fossa on back of the humerus. Humerus में नीचे olecranon fossa होती है. So if you have the olecranon fossa broken, that is what is fracture supracondylar humerus. Generally it will be less than 10 years old child who would come to you with that history of fall on outstretched hand. Clear? The displacement of the fracture fragment would by and large be posterior due to triceps pull. So you can very well see this olecranon is broken and this big muscle at the back, triceps, is pulling the distal fragment back. And the proximal fragment would go and create the complications, like you see over here, injuring the neurovascular structures, that brachial artery. So that is the usual pattern in this supracondylar humerus fracture. Young child as a 10 years of age with a history of fallen outer stand, the olecranon fossa broken, distal fragment pulled back by triceps, proximal fragment going in front and creating the complications. The treatment, as you very well understand, would involve close reduction plus internal fixation. And internal fixation here we do with those K wires. These are sharp wires. We drill 2 or 3 wires across the fracture site, and a wire is like a needle. To put a needle, you don't need to give skin incision. So you don't drain hematoma putting wires. So it is close reduction only. So that is what you do for this fracture. But yes, this is a fracture notoriously known for the complications. So you must remember the list of the complications. A neurovascular injury is possible. Brachial artery can be injured. You very well know. Then let me tell you, median nerve lies in the front, and especially its AIN branch, anterior interosseous branch, that can be injured. This is the fracture where even myositis ossificans is a possibility. Myositis, inflammation in muscles, ossificans, bone formation. So bone formation in muscles can also happen. The most common complication you find with this fracture is the development of a deformity called cubitus varus. Cubitus varus is also popular by this name, gun stock deformity. So all these complications are possible. But if you ask me the most dangerous complications that are possible in this fracture, compartment syndrome and Walkman's ischemic contracture. Terrible complications. So let me take you through some of these complications. So first of all, this cubitus varus. Now this is the elbow. Distal to the elbow, if you look at the forearm, it is deviated medially. So this is what I was referring to as gun stock deformity. Anatomy people refer to it as cubitus varus. Same thing. So this is what develops from malunion, wrong union of this fracture. This is the commonest complication of this fracture, but not very dangerous. Cubitus varus you find in fracture supracondylar humerus. Even a cubitus valgus is possible. So distal to the elbow, limb going laterally. So that's the elbow. But if you see the forearm here, it is going laterally, not medially. Here the forearm was going medially, here the forearm is going laterally. So when the forearm goes laterally, that is valgus. Cubitus valgus you find in a fracture of lateral condyle humerus. So last year FMG, all these questions were there. Pictures of cubitus varus or valgus, the causes behind varus and valgus. Okay, clear with that? So you must be well versed with the identification in these pictures and the causes behind these deformities. Compartment syndrome, I think, needs no mention. You are already very much familiar with it. See, the whole problem starts with fracture supracondylar humerus at the elbow that has led to a massive swelling. This massive swelling blocks the venous return of forearm. So because of this, the compartment pressure elevates, and this is what ends up with ischemia involving the forearm and hand. So basically fracture supracondylar humerus leading to ischemia in the forearm and the hand is what is compartment syndrome. तो एल्बो पे फ्रैक्चर हुआ, स्वेलिंग आ गई, फोराम का वीनस ब्लड हार्ट पे नहीं जा पाया, फोराम में स्वेलिंग बढ़ती गई, कंपार्टमेंट प्रेशर बढ़ गया, वेसल्स ओक्लूड, इश्कीमिया हो गया, नेक्रोसिस हो गया. When this ischemia happens, the first muscle that is involved tends to be this muscle, flexor digitorum profundus, and involvement of this muscle is what is diagnostic for compartment syndrome. Pain on passive stretch of fingers. So you are stretching the fingers, you are irritating this muscle, and the child is wincing in pain. So this is diagnostic. Yes, if you ask me the sign that has worse prognosis, it is paralysis, because paralysis is death. Some people think pulse is having worse prognosis. No, pulse is very unreliable sign. See, someone can have ischemia and still the pulse could be present. See, because this compartment syndrome is happening because the compartment pressure is increasing to around 30 millimeters of mercury. Now this is very less pressure to compress radial artery, ulnar artery, okay, because they have high pressure like 120 millimeters of mercury, the blood pressure. This pressure is basically damaging the muscle capillaries. So compartment syndrome is basically closure of muscle capillaries. Got the message? So that is why pulse is not a reliable sign. So if you are asked about diagnostic sign, pain on passive stretch because of FTP involvement. If you are asked about sign with worse prognosis, paralysis. If you are asked about most unreliable sign, pulse. So I hope you guys are thoroughly clear even with these important signs of compartment syndrome. समझ में आ गए हैं? Clear with that? Okay. Okay. Let me go through the chat also. Yes. So I hope everything is okay. Fair enough. So done with compartment syndrome, done with these important discussions. So let me just continue now into the lower limb part also. So upper limb के खूब सारे fractures हमने discuss कर लिए. Few more fractures I'll keep on going and discussing in the lower limb. The commonest complication you will find with the fracture shown over here. So this bone is talus. This is calcaneum. This is the neck of talus broken. A displaced fracture of neck of talus. It is popular by this name aviator's fracture. Now please, this aviator's fracture is already very well known to most of the undergraduates, because you have the dorsalis pedis artery that is traveling like this, that gives a branch that travels through the head, crosses the neck and goes on to supply the body of talus. So if you have a fracture involving the neck, the blood supply of the body will be gone. So this body will have a tendency to go into avascular necrosis. Now wherever AVN is one complication means there is some problem with the blood supply. So the other complication is always non-union. So this is a fracture that is known to have AVN and non-union. But mind you, this is a fracture that also involves this talocalcaneal joint. And since the joint is getting involved over here, osteoarthritis of this talocalcaneal joint actually tends to be the most common complication. So aviator's fracture is popular for all these three complications: avian, non-union and OA. But commonest of them is OA actually, which many people do not know. Because most of you are familiar with avian in this fracture and you quickly take avian as the commonest complication and the question goes wrong. So I hope you guys are like little bit cautious about this now. Okay, just looking at the chat. Okay, I hope the video lag is also okay. Fine. Okay, let me just see the chat again. Any fresh doubts are there, please post. Okay. Okay, I hope the audio visual is okay and no more queries are there, but it will be queries, just put them in the chat box. Now I was talking of avian. Avian is popular in talus, but it is also popular in this bone called scaphoid. See, here you have this bone called scaphoid, and by the scaphoid you have lunate. Now scaphoid has a very classical anatomy. There is a distal pole, there is a proximal pole, and this center area is called the waist. Now you have the radial artery going near the distal end of the radius that gives a branch that travels through the distal pole, crosses the waist to supply the proximal pole. So if you have a fracture involving the waist in the scaphoid, the blood supply of the proximal pole will be gone. So proximal pole will be undergoing avascular necrosis in cases of scaphoid fractures. And almost something similar happens in neck of femur fractures. So what you have over here is the profunda femoris artery here near the neck. Profunda femoris gives circumflex vessels that wind around the neck of femur. I am sure you must have heard the name medial circumflex femoral, lateral circumflex femoral. So the circumflex femoral vessels form an arterial ring around the femoral neck. Branches from the ring climb up to supply the femoral head. A fracture in the neck of the femur, the blood supply of the head will be gone and head will have a tendency to undergo avian. So fracture of scaphoid, waist fracture, proximal pole undergoes avian. Fracture of neck of femur, here head of femur undergoes avian, and in fracture of neck of talus, the body of talus undergoes avian. Clear with that? So please remember the three places where avascular necrosis is a very important complication. Again, a very popular scenario. Okay, avian questions coming from this area, your MCQs. So just two small things for you to identify here. This is the third metatarsal, almost the neck area, and this is all callus formation because this is a kind of a stress fracture, and this is lower fibula having a stress fracture. So what you see over here is that very popular march fracture, and what you see over here is that very popular runner's fracture. March fracture, a stress fracture involving the shafts of second closely followed by the third metatarsal. Runner's fracture, stress fracture involving the distal fibula. So please also remember these definitions, have a look at these x-rays. You might have to identify them up in your exams. A lot of questions now, they are based upon the images. So you must be clear with what is a march fracture and what is a runner's fracture. A stress fracture involving the shaft of second followed by the third metatarsal, that is a march fracture. A stress fracture involving the distal fibula, that is runner's fracture. Clear with that? Now this is just an image copy pasted from one of your previous FMGE exams, and this image has also been there in the NEET exam. So see this deformity. So what you see at this hip is flexion, what you see with the leg is adduction, and the foot is in slight internal rotation. Flexion, adduction, internal rotation. So from this deformity you have to pick up the diagnosis. So please, this is a case of a dislocation of the hip. Father deformity is classically popular with posterior dislocation of the hip. And Faber deformity, flexion, abduction, external rotation, is what you see with anterior dislocation of the hip. So two different dislocations at the hip have two different deformities. You can remember by them by these mnemonics: Father and Faber. Posterior dislocation, Father. Anterior dislocation, Faber. 98% cases of dislocation at the hip are generally posterior. So if there will be a hip dislocation, what you would usually find is a father deformity, flexion, adduction, internal rotation at the hip. Okay, that is right there in front of you. Clear with that, guys? Clear with that? Okay. And why posterior dislocation is seen in 98% of cases? Due to the mode of injury. It's a very classical pattern. We call it as the dashboard injury. You're sitting in the front of the car, and suddenly the brakes are put on, your knee goes and hits the dashboard gives a posterior force to the hip and the hip dislocates. So that's exactly what's called as the dashboard injury pattern. Clear with that, guys? So I hope you guys are clear with all this. यहाँ तक सारी चीज़ें समझ में आ रही हैं. I hope some revision things have happened and some things have come afresh to your mind. Okay, one very last important topic, and I would like to discuss, spend some time over it, is this particular question that is right in front of you. So please just try answering this one up. Just having a look at the chat once again. Let me see the chat once again. Let me just see. Okay, so just going through your queries in the chat, just to make sure that I don't leave any. Okay, so any more queries you can ask me. The whole idea of having this live session is basically to help you guys clear your queries. So anything you wish to ask me right now, you can just put it up in the chat box, and I would just try answering them up. Alright, now I'll just take you through this very important type of pattern of question, with so many concepts involved, bit of understanding involved. 76-year-old postmenopausal female, she's had a fall from the stairs. She sustained some kind of a fracture around the hip, the X-ray which is shown right in front of you here. You can see the neck of the femur broken. So there is neck femur fracture. Obviously 76 years old, postmenopausal, so the DEXA is bound to show osteoporosis. But then there are no serious comorbidities, so the doctor has planned this patient up for surgery. Now, what surgery would you do, or what kind of an implant are you going to use? Is what has been asked in the question here. So choice A, choice B, choice C, choice D, cancelous screws, hemiarthroplasty, K-wires, dynamic hip screws. You can just put in your answers in the chat box. Okay, and that will allow me to understand, to know the level of your understanding, and of course then I'll be able to clear this up to you. Okay, so please just feel free to put your options in the chat box. Okay, now this particular question requires understanding of this very important zone, the fracture of neck of the femur. So I'll first take you through this fracture. The types. This is a fracture also popularly called by this name, unresolved fracture, because there are so many controversies that surround this fracture regarding the treatment part, management part, other things, that some people simply call it as the unresolved fracture. A repeat MCQ from one of the previous FMGE exams. Now, this fracture of neck of femur broadly gets categorized into these two categories. One is the intracapsular fracture, and the second is the extracapsular fracture. Now, please, this is the greater trochanter, this is the lesser trochanter. Capsule in neck of femur is basically attached along the two trochanters. So in that green color you see, I have basically drawn the attachment of the capsule. तो ये intertrochanteric area के along capsule लगा होता है, like I've drawn in that green color. Now you can very well imagine that any fracture that will be in this area here will be within the capsule. So a fracture here will be called intracapsular, and any fracture that involves these two trochanters, greater and lesser, will be going outside the capsule, and this particular fracture here will be called extracapsular. So in a simple way, this extracapsular fracture is basically a trochanteric fracture. तुम्हें एक भी ट्रोकेंटर टूटा हुआ दिख गया, that is extracapsular fracture. Clear? So you find the trochanters are intact, that is intracapsular. You find the trochanter is broken, that is extracapsular fracture. Extracapsular fracture is generally seen after the age of 70 years. Intracapsular fracture is generally seen in this age 40 to 60 years. Otherwise, they are all fractures of old age only. Yes, both the fractures, they have a common deformity, that is shortening and external rotation. But you find less shortening and external rotation in the limb with intracapsular, but you find more shortening and external rotation in the limb with extracapsular category. Clear? So extracapsular you find bit more of deformity, you find it in bit old people. Intracapsular find in relatively younger people with less degree of the deformity. The two fractures also have different approaches to treatment. See, extracapsular fracture has very good union rates, very good union rates. Rather, if you don't treat it nicely, it malunites. It malunites basically in this shortening and external rotation position of the limb. But intracapsular fracture, shortening external rotation is very less. So here problem is not malunion, the problem here is non-union. जुटता नहीं है. And then you very well understand you also have a risk of avascular necrosis. Remember that diagram, profunda femoris artery forming that arterial ring. I told you. So you have the profunda femoris artery here, it forms that arterial ring, then the branches go up supplying the head. So when there is intracapsular fracture, this arterial ring supply to the head is gone, but when there is extracapsular fracture, no problem with the blood supply. So intracapsular fracture you are dealing with non-union AV, and extracapsular fracture you are dealing with malunion. There is a good union potential. So there is a different behavior between the two types. So it is very important that right at the onset of this question here, you decide whether you are dealing with intracapsular fracture or extracapsular fracture. Like if you see these trochanters broken here, the capsule is penetrated. So the particular category being talked of here is extracapsular fracture. I hope you can see this age, 76-year-old. Extracapsular fracture, more than 70 years. So this also gives you a hint you are likely talking of extracapsular fracture. Clear with that, guys? So neck of femur fracture के question में पहला step यही रहेगा that you have to decide like whether you are dealing with intracapsular fracture or extracapsular fracture, because the two fractures are basically having different kind of outcomes. So please don't rush on to this option hemiarthroplasty, please, like you do. Most of the people were answering C. You talk of hemiarthroplasty, here it is crying. See, this is extracapsular fracture. This was going to unite. Very good union rates. And you're talking of excision of this bone and putting in this hemiarthroplasty prosthesis in place of head. It is like stealing a viable kidney. Crime. This bone is to be fixed because it can unite. Had it been intracapsular fracture that is not going to unite, that is where you have to talk of hemiarthroplasty. So please make sure you differentiate the two fractures before putting in your answers. See, if you talk of extracapsular fracture, it unites. The problem is it unites in wrong position, malunion. So you just don't want it to unite in wrong position. So you fix it with this special screw. That is called a dynamic hip screw, and screw fixation neck of femur close reduction because you don't need to drain the hematoma. So extracapsular fracture will be treated by close reduction internal fixation, where this internal fixation will be done by this special screw that's called a dynamic hip screw. Clear with that? So that is how you treat extracapsular fracture. Intracapsular fracture. Now this is that category where you are concerned with non-union, and this is that category where you are concerned with avascular necrosis. So here your treatment is basically decided by age of the patient. When you are dealing with people over and above the age of 60 years in this category, this is where you go with hemiarthroplasty. Clear? And here also in young people chances of union are there, so you go with close reduction internal fixation only, but internal fixation here is done with multiple cancellous screws like you see over here. Clear with that, guys? Clear with that? So I hope you have understood that up. Okay. Raji, you were talking of hemiarthroplasty, some other people who were talking of hemiarthroplasty. So I hope you guys are clear with the mistake you were making. So neck femur में पहले decide करना है extracapsular fracture है intracapsular. Extracapsular में dynamic hip screw. Intracapsular में you go by the age. Old people you do hemiarthroplasty. Young people even intracapsular you do screw fixation. Because intracapsular union is a problem, so you can think of hemiarthroplasty. Extracapsular fracture will always unite. You just don't want it to unite in wrong position, so you fix it with a screw in a proper position. So are you guys clear here? This particular question, it was extracapsular fracture, so I am talking of dynamic hip screw fixation, not hemiarthroplasty. Hemiarthroplasty would have been in intracapsular fracture with age of 60 years. So had this patient had intracapsular fracture, then we would have talked of hemiarthroplasty. But intracapsular fractures generally occur in this age 40 to 60 years, maybe 60 to 70 maximum, but after 70 we generally find extracapsular fractures. So please be careful with that. Now let me tell you a little bit about this non-union part also. Often neck femur fractures also go into non-union. So if these fractures go into non-union, then how you deal with that non-union part, that is also important, because you know non-union is like a part and parcel of fracture of neck of femur intracapsular variety, the intracapsular variety to be specific. So what options would you choose in cases of non-union? One is you can graft, because the treatment of any damn non-union is bone grafting, and for bone grafting you can use a spare bone in the body like fibula. That is one option you can use in cases of non-union intracapsular fracture neck of femur. Otherwise, there is another very popular treatment option, a well-known treatment option, that is called Mayer's procedure. This tends to be a vascularized muscle pedicle grafting using a muscle that's called quadratus femoris. Now this is a spare muscle around the hip. We shift this muscle over the fracture site. thereby improving the vascularity of the fracture site. That is simply Mayer's procedure. So that is another option you can choose in this scenario. Otherwise, there are two popular osteotomies. Powell's osteotomy, that's one, and McMurray's osteotomy, that is second. So these are also popular treatment options you can choose. Basically, both these options, they alter the weight bearing forces around fracture site. So basically the weight bearing forces now start compressing the fracture site after these osteotomies. So these are also some treatment options that can be used in cases of non-union. So if you are dealing with neck of femur, you decide intracapsular or extracapsular, you treat accordingly. Extracapsular would mostly unite. Intracapsular, because of the vascular tissue, might go into non-union. If it goes into non-union, then you can choose these treatment options for cases of non-union in intracapsular fracture. So I hope you guys are clear with that. But questions in neck of femur are not that simple. They generally come in a very complicated way. So let me give you a small chart, a flow chart to decide treatment in neck of femur, and then I go back and tackle this question up with that flow chart so that you remember things on a spinal level. Suppose you are dealing with a fracture of neck of femur. First you decide whether it is extracapsular fracture or what you are dealing with is the intracapsular fracture. If you are dealing with extracapsular fracture, your treatment will be close reduction, internal fixation. And this internal fixation will be done with the dynamic hip screw, because all that you want to tackle over here is malunion, कि गलत ना जुड़ जाए तो screw से fix करना. That's it. In intracapsular fracture, you are rather tackling non-union because of that blood supply issue and AVN. So here your treatment goes in a different way, goes by the age. Suppose someone has age over and above 60 years. This is where you can straight away go and do that wonderful surgery that you are very much familiar with, the hemiarthroplasty, that partial type of a hip replacement. Replacements are only kept for people of older age because they have a life of 15 to 20 years. They are not kept for younger people. If a young patient comes to you less than 60 years with this intracapsular fracture neck of femur, here you must check how long it has been the time since injury. So please just understand, time since injury could be an acute one less than 3 weeks. Time since injury could be a chronic one more than 3 weeks. Now please, intracapsular fracture is known to go into non-union, and someone has not taken treatment for more than 3 weeks. So this simply tells you that this is actually a case of non-union. तो बहुत बार एग्जामिनर नॉन यूनियन वर्ड डायरेक्टली नहीं बोलता, वो टाइम से इंजरी से बोल देता है कि किसी ने 1 महीना ट्रीटमेंट ही नहीं कराई, सो इज बाउंड टू बी नॉन यूनियन. बिकॉज लेट मी टेल यू, इन यंगर एज फ्रेश फ्रैक्चर्स you will treat with close reduction internal fixation with those multiple screws. But same fractures, if they are old, there will be cases of non-union. So here you will have to choose a treatment option for non-union, like bone grafting, improving that vascularity that I told you is Mayer's procedure, or doing that McMurray or the Powell osteotomy to improve the weight bearing forces compressing the fracture site. So these are the options to be chosen in people who are cases of non-union. They generally the delayed cases, so don't take treatment timely. Clear with that? So with this chart, we'll get a practical approach to cases of neck of femur, very good practical approach to neck of femur, Okay, so you can just draw these flowcharts with me, maybe take a snapshot and keep them with you, because with these snapshots, it will be very easy for you even to keep a track of this question on neck of femur on an immediate basis, and it will be like uh, no time that you will take to uh, you know answer this question. So I'll just give you the example here. A 50 years old male is come with this fracture of neck of femur that is more than 3 weeks old. So what would be like the scenario, the best treatment? So first of all, nothing is mentioned here intracapsular or extracapsular. When nothing is mentioned, this fracture of neck of femur is generally taken to be intracapsular. But then 50 years old again hints you it is intracapsular, because extracapsular fracture we generally see after the age of 70 years. So indirectly, examiner is talking about intracapsular fracture. Now this is intracapsular fracture neck of femur. The age is given to be 50 years. And examiner says the history is more than 3 weeks old. So for 3 weeks this person did not take treatment, so he is now a case of non-union. So let me go to this table. Intracapsular fracture neck of femur. 50 years was the age, less than 60 years. And time since injury was more than 3 weeks, case of non-union. So you have to choose a treatment from this box. So the best pick here automatically becomes McMorris osteotomy. Now if you have to pick up hemiarthroplasty, the age had to be more than 60 years. It is less than 60 years, so this is gone. If you have to fix with screws, the injury time had to be less than 3 weeks. It should not have been non-union, so out. And total hip replacement is basically for AVN cases. They are delayed cases who come with pain. AVN is not immediate complication, takes time. AVN, avascular necrosis. Necrosis means death. Death can never be reversed. Death can only be replaced. So replacement is mostly kept for AVN cases. Clear with that? So I hope you are clear with this neck of femur. You have drawn this whole flow chart. You are clear with that up. So that was a quick round off for all the fracture area important topics in zones. I'm done with that. So any queries, please feel free to ask me. Please feel free to put your answers in the chat box. Okay. Any last queries? I'm looking for your queries in the chat box. So your exam is around the corner. Go with confidence. Go through the class. Okay. Okay, so no more queries. Okay, so then I think I can just close up the session. So hope you enjoyed the session. I'm done with all the fractures. So check out the app and go through the entire course. In case your concepts on orthopedics have not been made, you missed out on the classes. Okay, and